Thank you. Please be seated.
Ladies and gentlemen, I hope you had a good lunch. We're going to continue all the testimony. Doctor, you're still under oath. Ms. Menashe.
Thank you, Your Honor. Doctor, good afternoon.
Good afternoon.
Just to go back, I know we had gone through a number of records with respect to patient Ryan Hayes. Is that fair to say?
Yes, it is.
Covered at least 4 doctor's notes with respect to the condition of Mr. Hayes. We went through Dr. Klossers, Dr. Morse, Dr. Varghese, and then the initial doctor that did the physical, Dr. Epen. Do you remember that?
Yes.
Okay. I want to go now to some other findings that you made in your report, if we could, still on Ryan Hayes, Doctor. Ryan Hayes, page number 7. Do you see where you indicated that Dr. Husel never placed a consult for the palliative care service?
Yes.
To evaluate or discuss the DNRCC with Mr. Hayes' next of kin? Do you see that as your 7th finding in this case?
I do.
And I know we've discussed it, but there was palliative care service, while mandatory, was an option offered at Mount Carmel West. Is that correct?
It is correct. Palliative care was not mandatory at Mount Carmel West.
I wanted to just go here to what's marked as Joint Exhibit 2, page 373. This appears, does it not, to be a palliative care consult for Ryan Hayes, correct, Doctor?
It does, yes.
And I wanted to go again, these are my highlights. History and of present illness. If you could look here, what is the doctor name that appears there?
That's not a doctor, that's a nurse practitioner.
Yes.
CNP,
sorry.
certified nurse practitioner.
Certified nurse practitioner. I'm sorry, but the name?
Chowan.
Okay. And then,
I'm sorry, Chauvin.
And then right here, does it not indicate, and if you could tell the jurors the time of the visit was what time of the palliative care consult?
The time was 2:30 in the afternoon.
On what date?
On April the 2nd.
So the date that he arrives, he being Ryan Hayes, to Mount Carmel West, there is in fact a palliative care consult done.
I do see that, yes.
And and yet his course of treatment is through the 4th, right?
Correct.
And then you see down here, palliative care team was consulted to assist with the coordination of care.
That's correct.
Brother Ron at bedside.
True.
Right? So I just want to go back then, Doctor, to this note where you indicate here on 7, we know that Dr. Husel was not working the day shift when the decision was made, but we also know, do we not, with respect to your finding as to number 7, that that's inaccurate?
That's correct. It appears a palliative care consult had occurred on the 2nd.
And then I want to go to your findings with respect to, again, Ryan Hayes, but now we're moving on to number 8. That the medical records did not include any documentation that Mr. Hayes' condition had deteriorated to a point where further medical or surgical intervention would have been unlikely to stabilize his condition. I want to go back to, and then further you talk about there's no cardiopulmonary documentation to suggest that this patient was terminal. Do you see that as well?
I see that.
Doctor, I remember on your direct examination you talked quite a bit about the hypothermia protocol. Do you remember that testimony?
I do.
And that's one of the things that you indicated that could have been done to cool a patient?
Correct.
And when Ms. Scrub asked you about the actions or lack of actions, you talked about that cooling protocol as a way or a medical procedure intervention that could have been done by Dr. Husel that wasn't done in a number of instances. Do you remember that testimony?
That's correct, in a number of instances.
Showing you what's been marked is Joint Exhibit 2, page 22. to 2.7. Does this appear to be that Closser progress note that I had showed you previously?
Yes, it does, April 3rd.
And just for the record, just want to make sure, the progress note is page 22 to 27, is I have it marked for the exhibit. Doctor, want to go to page 26 of that progress note. That line I just highlighted right there with under cardiology. Would you agree with me that it says due to high pressure, and we know that's vasopressor, right?
That's true.
So the cardiologist, Dr. Closser, or Dr. Closser's pulmonary. The pulmonary doctor in the ICU notes, due to high pressure requirements, patient did not undergo hypothermia protocol. Do you see that?
Yes, I do see that.
And this progress note is from April 3rd?
Yes, April 3rd.
And the date of death for Mr. Hayes is the 4th?
Correct.
And would you agree with me that that is a daytime shift entry?
It is. It's 4:07 in the afternoon.
So with respect to Mr. Hayes, we know why Dr. Closser found that he was not a good candidate for cooling. Is that right?
Yes, in regards to Dr. Closser, that was his entry.
It's noted on that medical record that he can't get that hypothermia protocol, he being Hayes, because of the high vasopressors. Do you interpret that through your work as an expert to mean that that was a, do you say counter indicator?
Contraindication.
Contraindication. And tell the jurors what a contraindication is.
A contraindication is when there is something in the patient's history or physical examination that would usually speak against offering treatment.
So here we've got him on vasopressors, no cooling, according to Dr. Closser.
According to Dr. Closser.
Just want to go now to, with respect to Ryan Hayes, your finding on 29. And I know you're talking about Dr. Husel here, but we know that the decision was not made by Dr. Husel or during his shift. But would you agree that at the end here it says at least a critical care medicine physician should not draw a conclusion with respect to futile without allowing a reasonable time to pass? And then do you see how you write greater than or equal to 24 hours?
Correct.
Just want to go back to, if we could, the history and physical, Joint Exhibit 2, page 12. This is done by Dr. Epen.
True.
Very first doctor that sees Ryan Hayes. Do you agree with me on that?
He was one of the first doctors to see him.
Okay. And he indicates here, the patient does not have any chance of survival. Do you see that?
I see that highlighted.
And then going on to progress note, Joint Exhibit 2, page 32, does this appear to be a note by a different physician?
It does.
And would you agree with me that progress there is noted to be terminal?
Yes, Dr. Vashani does indicate in his note, in his opinion, he believed the patient to be terminal.
I just want to go back to the history and physical. You would agree with me that 24 plus hours passes from this determination to when Mr. Hayes is palliatively extubated, correct?
That is correct.
Let's go to Ms. Belisari, if we could. I just want to, this is page 30 from your findings with respect to Ms. Belisari. And as highlighted here, you note it appears that he being Dr. Husel, failed to clearly delineate that Ms. Belisari's status was not terminal and further medical surgical interventions had not been exhausted. That's your finding with respect to 30 on Ms. Belisari, correct?
Correct.
Just want to go through, if we could, Joint Exhibit 1, page 127 to 128. You are aware, are you not, that Dr. Ralston is an ICU doctor?
I am, yes.
And does this appear to be Dr. Ralston's note?
Yes, from May the 1st.
And I want to go to, I'm sorry, that's May 1st
Yes,
is
May
his
the-
note? And the patient passes on the 10th.
Correct.
So 9 days in between?
That's true.
This is Dr. Ralston's note, is it not? Critical care, 42 minutes.
Correct.
He writes, without ventilator or pressors, patient would die. Is that right?
His assessment on May the 1st was without that continued support of pressors and ventilators, the patient would die.
And that's page 128, right?
Correct.
Okay, and then the following day, showing you what's been marked as Joint 1, page 145, appears to be by Dr. Fagan. Do you see that?
I do see that.
Okay. And it looks like when addendum by, does that happen when there's a resident?
Correct. The attending is expected to authorize and authenticate the note and then put her or his supplemental addendum, which is what appears Dr. Fagan did in this case.
And this note appears to be on 5/2, is that correct?
Yes, May the 2nd at 9:40 in the evening.
So we have here, patient is on full life support measures without which she, being Miss Belisari, could not survive.
Yes, that is the statement.
And then, and I'm sorry, but Dr. Fagan, ICU doctor?
Yes, my impression of reading the charts was that he was the ICU doctor supervising the resident.
And then 6 days later, on May 8th, I'm showing you what's been marked as Joint Exhibit 1, page 250 to 251. Does this appear to be a progress note authored by ICU Dr. Moody?
It was authored by Dr. Moody. I don't recall if she was an ICU doctor or a hospitalist, but she did author this note.
Okay. Flipping to page 2 of that, indicates, does it not, that she spent 37 minutes with the family on May 8th?
Correct.
She notes the family expressed to me the fact that Miss Belisari is a very private and modest woman who would always express to them her wishes that she not be on life support.
Yes, that was in Dr. Moody's note.
And if you recall, this was on a Friday. Does that sound familiar?
I don't specifically remember which day of the week it was.
Okay, and then there's discussions right down here that Dr. Moody has about the vent withdrawal, changing the status. Would you agree with me on that?
Yes, and that does appear to corroborate that this conversation was on a Friday because they wanted to support her over the weekend.
So in this note, it's Dr. Moody that's having the conversation with the family, and it appears overall it was 37 minutes.
That's correct, from noon to 12:37.
And then I just want to go, if we could, to page 259 of the Belisari records. Do you see this separately with respect to where I've highlighted there is a high suspicion of malignancy? Do you see
Yes,
that?
I do see that.
Although the final pathology diagnosis is pending. Tell the high suspicion of malignancy is that there was a suspicion that her cancer had spread.
Well, there was a specific suspicion that she had cancer, malignancy. The word spread would be metastases, which is not mentioned in the note.
Sorry, so there was a high suspicion that she had cancer.
Yes.
Now, going, and we know that you said when you talked about pain during dying you told this jury on direct that those with cancer can often experience pain while dying.
Yes, that's a true statement.
Showing you what's been marked as Joint Exhibit 1, page 278, 279, with respect to Ms. Belisari. The date appears to be the same day that she passes. Is that fair?
Correct. That was May the 10th.
So I want to go to the 10th because we have the notes, do we not, from the doctor about her being on full vent support from the 1st, the 2nd, the 8th, and I just want to close out with the 10th. Dr. Moody has indicated, has she not, that the patient is on full life support measures, including vasopressors and mechanical vent. And then the next sentence says, does it not, without such measures, she would not survive. Do you see that?
Yes, I do see that.
I want to go to a question that you were asked about in your deposition. If we could. And your deposition, when I say that, to orient you, I mean June 21st, 2021. When you were asked about the time someone that's on full vent support would expect to live once the ventilator is turned off. Do you remember those questions?
Correct. There was a series of questions regarding that topic.
And your answer was it not? Well, I would answer that if the patient is fully vent dependent and the vent is withdrawn, then yes, in that patient, if they're completely dependent on gas exchange from the ventilator and the ventilator function of the ventilator driving the tidal volume, then they would not be able to exist more than 4 or 5 minutes without the ventilator.
That's correct. If they're fully vent dependent, that there's only a 4 to 5 minute oxygen reserve in the brain for the human body.
And I think you testified on direct that after she was extubated, she died 8 minutes later.
That's correct.
Just a couple other things with respect to Ms. Belisari. Showing you what's been marked as Joint Exhibit 1, page 127, 313 to 314. Dr. Husel is the one that intubated this patient Belisari, is he not?
That's correct.
And we know that because of this note. Is that correct?
Yes, this appears to be the procedure note.
And so I want to talk about, if we could, one moment. Where's the intubation sheet? Yeah. I'm looking for the sheet. One moment, Your Honor. Just need an intubation sheet. So I will go to you talked about with respect to Ms. Belisari. Do you remember talking about the paralytics?
Yes, I recall that.
Oh, never mind. My mistake. I'll withdraw that question. I just want to make sure with respect to Dr. Moody's note on the 10th that I showed you that was the day that she passed, that she indicates, see my separate note regarding discussions reached during family meeting on 5/18/15. And do you see that the patient is now DNR-CCA?
That is correct. I see that.
And that, again, was a Dr. Moody note?
Yes, that's the Moody note from May 10th.
just go back to something you testified to on direct, showing you what's been marked as Defendant's Exhibit Hans 19. If I heard your testimony right, and I just want to make sure, doctor, that you said that she was not given Dilaudid during her stay at the hospital, that she was given a medicine called Precedex or something to that effect. Help me, if you would.
Precedex?
Yes. Fair to say, showing you her medical administration record. Does that look like this is for patient Ms. Belisari?
Yes, this is the MAR, medication administration record.
Right. Just want to indicate there that on May 1st, she is given Dilaudid. Does that look true?
Yes, there was an order placed for Dilaudid on May 1st.
And we know, because we're looking at a MAR, that this means these medications were actually given.
Correct.
And then on the next page on 5.1, again, there appears to be an administration of Dilaudid.
That's correct.
And then on 4, and this is a infusion, is it not?
Yes, this is an infusion.
And the first one is an infusion too, so it's giving the medication on a continuous basis.
That's true. It's infused into the patient through her IV.
And then we have here on 5.4 that she's given another continuous infusion of Dilaudid.
On 5.4, the dose was increased.
The dose is increased from 1 milligram per hour to 2.
Correct.
And that's entered by Dr. Husel and Nurse Springer. Do you see that?
That's correct. The original order was placed by Dr. Husel.
So that's an example of fractured dosing. Increase is needed.
It's an example of incremental titration upwards, yes.
Increment. And then we have on 5.5, the Dilaudid, and it's changed on 5.5 to the medication that you had testified to on direct. Is that now does that help refresh your recollection, doctor?
Yeah, so this indicates that the Dilaudid has been stopped. It's gone to 0 in order for the other medication to be initiated.
So she was on Dilaudid while she was at the hospital and not just on the medication that you testified to.
That's correct.
I want to go to Mr. Timmons, if we could. You know what? Sometimes it happens. If we could go back to Mr. Hayes, doctor. Appreciate your letting me toggle back and forth. Defendant's Exhibit RH3. Mr. Hayes, you testified that after you had written your report on Mr. Hayes, you had an opportunity to review the coroner's report.
Yes, that's correct.
And hate to ask the obvious, but you are not a forensic pathologist.
No, ma'am, I am not.
And on this final report by the Franklin County coroner, the cause of death is listed as what?
The cause of death is hypoxic ischemic encephalopathy, which is synonymous with anoxic encephalopathy.
And the manner of death is marked as an accident?
It is, yes.
And then you've got the due to, and we show the resuscitated cardiopulmonary arrest, and then you've got the acute mix of drugs.
Correct.
Want to talk about those drugs. You remember that Mr. Hayes was the patient that was found in his bathtub by his sister?
That's correct.
And here in the autopsy report where it notes how injury occurred, it says what?
It says consumed carfentanil, fentanyl, morphine, and ethanol.
Then I want to go back to the toxicology that you testified to. You recall, I presume, that Mr. Hayes' stay in Mount Carmel West was April 2nd to April 4th.
Yes, that is correct.
And so then April 2nd would have been the day that he arrived at Mount Carmel West.
Exactly.
You were asked questions about the blood draw that was done. Fair to say this blood draw, as you now have come to understand the medical records, was done as soon as he arrived at Mount Carmel West?
Yes, it was obtained in the emergency room, apparently.
So this captures the drugs that he had in his system upon arrival.
Correct.
Your testimony about ethanol it's just noted there as point 110. You would agree with me, would you not, that norfentanyl is a metabolite of fentanyl?
That's correct.
But carfentanil is actually something distinctly different.
Yes, it's another semi-synthetic narcotic. It's a similar structure, but even more powerful than fentanyl.
Since you mentioned its power comparison, do you happen to know that carfentanil is 100 times more potent than fentanyl?
That is correct, yes. Usually it's not used in human medicine. It's primarily reserved in veterinary medicine for things such as elephants and zoos because it's so powerful.
It's like a tranquilizer.
Yes, exactly.
And so in this individual, if we could go up here, we have a positive for carfentanil.
Correct.
And also we have a positive up here for what other drugs?
There was a positive for morphine, and then there was also a positive for naloxone, which is the reversal agent. And then it said positive for nicotine and cocaine.
And cocaine as well, is that right?
Yes, it was positive for cocaine. Again, they didn't appear to quantify that. They just indicated positive. I'm sorry, I take that back. Not cocaine. Maybe it was flipping so quickly. I think it was codeine, which is the metabolite of nicotine. So nicotine and codeine.
So he's got carfentanil, morphine, some nicotine.
Correct. And alcohol.
And alcohol, and then he has fentanyl in his system.
That's correct.
And so when he arrives, if we could go back to how the injury occurred, those are the same drugs that are listed, are they not, as to the forensic pathologist findings as to what he had consumed?
That's correct.
Carfentanil, fentanyl, morphine, and ethanol.
That's true.
And actually, if you know, carfentanil isn't even allowed for use in humans, medically speaking.
Exactly. It has no use within the hospital or in humans.
Now, Mr. Timmons, thank you. Just want to start with your findings with respect to Mr. Timmons on paragraph 34, that his status was not yet terminal and further medical surgical interventions had not been exhausted. Do you see that as one of your findings?
Yes, I do.
Showing you what has been marked as Joint Exhibit 11, page 31 to 32. Does this appear to be a note from Dr. Ralston?
It is, yes.
This note is the day before Mr. Timmons passes?
Correct.
Just want to go at the top of that progress note that is authored by Dr. Ralston that notes, does it not, without the ventilator, pressors, or interventional critical care, patient would die or have organ damage. Do you see that note?
Yes, I do see that note.
And then further, it just indicates no family at bedside.
That is true.
Critical time of care that he notes there is over 2 hours that he spent with Mr. Timmons. Does that look right?
That's correct. He spent 2 hours and 1 minute caring for Mr. Timmons.
Then I want to go to what I'm showing you is Joint Exhibit 11, page 10. This is a history and physical done by a doctor upon Mr. Timmons' arrival.
Yes, that's correct. The admitting physician team.
This is on 10/23.
So Dr. Batashi signed it on 10/23. The note was generated by Dr. Sean Kim, who was the senior resident, I believe.
And Dr. Sean Kim's name is right down there. Would you agree with me on that?
Yes, that's correct.
Perfect. Thank you for that. So, and that's why it says addendum by. So we have a physician overseeing the resident, as you discussed. So notes from, as approved by Dr. Batasti, indicate, do they not, that I have seen and examined the patient with Dr. Kim, and that there appeared to have been reviewed the lab data, vital signs, and diagnostic studies. Do you see that?
Yes, I see that.
And LLE is tight, there are no pulses, and poor cap refill?
Correct. LLE is left lower extremity is tight, and there are no pulses or poor capillary refill.
And this is from the leg?
Yes, the LLE refers to the left leg.
And then the following note is connected, is it not, where it says he's going to OR urgently for compartment syndrome, remains on pressors for shock.
True.
On CRRT? And
yes.
If you could tell the jurors what CRRT?
CRT is continuous renal replacement therapy. It's continuous hemodialysis.
Because his kidneys are failing.
That's correct, due to the rhabdomyolysis.
And the note here by Dr. Bastati, assume he approved from Dr. Kim, is high mortality risk.
That's true.
I want to talk about this finding that you made with respect to Mr. Timmons, number 17. What does Halidal do?
Halidal is an antipsychotic that also has some sedative properties to it.
Doctor, would you like to review the MAR or the order set to see if Mr. Timmons was actually ever either ordered or given Halidal?
Yes, I haven't memorized the MAR, so I'd have to look to see whether or not it was given.
Sure, we can come back to it because I know it'll take you some time. But perhaps at a break, I will, oh, here it is. No, this is, I will give you the MAR so that you can.
They're all in there. Every last one of them.
Okay.
You just have to flip it over into the right one.
Then I want to just go. I want to go to, while I circle back to that, I want to go to Mr. Timmons' autopsy report showing you Defendant's Exhibit JT3. As you recall, Mr. Timmons was the one that was found in his basement on an overdose. Do you recall that?
That is correct.
And the duration of the time for which he had been unresponsive in his basement, fair to say that was unknown.
That's true. It was documented to be unknown.
There was even a note that it could have been as long as up to 48 hours.
Correct. Based on the severity of his muscle injury, it was believed to be longer than 24 hours.
I want to show you with respect to his MAR, while I wait to circle back on the full MAR. On 10/22, he arrived at Mount Carmel West?
Correct.
And passed on 10/24?
Exactly.
Just want to show you, if we could, we know, or you know, based on your review of the records, that Mr. Timmons had a history of opioid use.
True.
And you also know that, based now on the review of the coroner's report, that he had tracks in his arm. Do you remember that?
Yes, the coroner did find evidence of both recent and remote needle tracks from injectable drugs.
Would you agree with me that the recent and the remote were probably injection sites that had healed over with some time?
True.
And so it was almost like a scar and more of an unscarred needle entry?
Yes, I would agree with you that it was a scar from prior needle puncture.
And then it also, the coroner's report indicated that there was a note that there had been recent needle use, correct?
Yes, there was also evidence that he had recently injected himself with drugs.
So I just want to, and I ask you these questions with respect to tolerance. He arrives on 10/22. On 10/23, do you see this order for fentanyl here?
I do, yes.
And this order right here is an order for 300 micrograms. This is an infusion order, is it not?
Yes, this is a continuous infusion of fentanyl.
And we know that because it, not only from this down here, but it says continuous infusions up there.
Correct.
The person ordering this,
Dr. Husel?
then this right here, we know later in the day on 10/23, tell us what happens with that fentanyl infusion.
So it appears later in the day that the fentanyl infusion is reduced by 50%. It's essentially cut in half.
And the ordering physician on that?
Well, it's attributing the original order to Dr. Husel, but this occurred during the morning at 10:45, so it would have been a different physician or team that would have triggered the reduction, unless Dr. Husel was still there. But you can see it's still attributing the original order to 8 minutes after midnight.
This is right here.
Correct.
The original order?
Yes.
And so then, at some point in the next shift, still getting fentanyl on an infusion base.
That's correct.
And then same here is now 200?
Yes, at 8 o'clock and at 8:28 in the evening, the dose had been slightly increased from 150 micrograms per hour to 200 micrograms per hour.
And the HR just so it's per hour.
Per hour.
You get that per hour.
Correct.
And when we see, doctor, an order, let's say here at 10:45, and then the order seems to be modified at 20:28, we can presume, can we not, that in those 2 hours in between, that person got the 150 per hour.
Correct, unless there's a specific note in the nursing orders that it's been held because of transferring the patient to test or OR, one could presume that the patient received the medication.
So I asked that because this original order here is like 12:44 a.m.
Correct.
for 300 micrograms an hour.
Yes, that's true.
And then the next time that medication is adjusted is at 10:45.
Correct.
So for approximately 10 hours, Mr. Timmons was receiving 300 micrograms of fentanyl.
Yes, again, at some point he did go to the operating room. I'd have to look back to see the exact time that he went to the operating room, but at least based on what's in the MARS, it would appear that he received the infusion at 300 mics per hour through that period of time until it was cut by 50%.
I think I have the operating room note. I will try to find it. But generally, principle 300 an hour means you get 300 every hour until either the order is discontinued or it's modified.
Yes, that's a true statement.
So then I'll go to Mr. Timmons, the autopsy done in this case. And like Mr. Hayes, this was an overdose situation as it came into Mount Carmel West, correct?
Yes, I would agree. He wasn't clearly an overdose case.
And cause of death as determined by the Franklin County coroner was what?
Recent cocaine and fentanyl use.
And then the manner of death is noted as?
It was described as an accident.
Why don't you just turn, if we could, to this page right here, how the injury occurred. The coroner in this case noted used cocaine and fentanyl.
That's correct.
And the word used is appropriate because, like with Mr. Hayes, this urine draw was done right when he arrived at Mount Carmel West.
Yes, it correlates with his time in the emergency room, and ante-mortem means while still alive. And again, the date of admission correlates with this draw.
And so just so that the jury is clear, I'll just show a progress note. He arrived on 10/22, and this urine draw is 10/22.
True.
And so in his urine, positive for fentanyl.
Correct.
Upon arrival at the hospital, and then positive for nicotine.
That's true.
Just from smoking a cigarette, like.
Correct.
And then on page 2, it's positive for cocaine.
That's correct.
So let's discount the nicotine. The finding by the urine that when he arrived at Mount Carmel there was fentanyl and cocaine in the system explains, or at least correlates, with the finding that Mr. Timmons had used cocaine and fentanyl.
Yes, it appears that the pathologist and the coroners got that information from the ante-mortem urine specimen.
I think. Did I miss a ketamine finding?
Yes, I did see that when the urine was drawn, they did also detect ketamine in the urine specimen.
Right here.
Correct.
And tell the jurors what ketamine is.
Ketamine is a sister of LSD. It is able to be injected. It's used often in veterinary medicine and also in anesthesia and critical care to either induce anesthesia or to relieve bronchospasm in people that have bad asthma.
But like carfentanil, it's a drug that one would expect to see with animals and not with humans.
No, I mean, whereas carfentanil is never used in humans, we use ketamine selectively. It's more often used in veterinary medicine, but anesthesiologists and critical care will use it with tremendous caution. But it is a drug of abuse, unfortunately. The last decade, people do abuse it on the street.
And that's showing as positive in addition to the fentanyl and the cocaine.
It is, yes.
For Mr. Timmons.
Correct.
I'm going to go to Miss Hodge, if we could. I can't find that in the sheet. 1 second. Oh, just where I left it. Some people have a filing cabinet, Doctor, you know? So I wanted to just go back to, I believe that Ms. Grubb, or I'm sorry, the prosecutor showed you on your direct an order for fentanyl that was ordered and then showed to be administered to Mr. Timmons.
Correct.
And this will help answer 2 questions. You mentioned and this is the anesthesia record?
It is, yes. This is the electronic version of the anesthesia record.
Indicating from page 3 of 4, but this does appear to belong to Mr. Timmons.
It does, yes. And you can see below that it's the fasciotomy of his left leg where they took him to open his leg up.
Right, and so I wanted to just, because the time of his surgery, you indicated you just weren't sure. Does this help refresh your recollection as to 12:05? It says surgery start. Do you see that, Doctor?
Yes, if you actually go up just a little bit, it'll show that at 11:44 he was transported from the ICU into the OR, and then the surgery started roughly 15 minutes later, as you had mentioned, at 12:05, and then it concluded at 12:41, or 12:34.
Yes, 12:41. So it looks like the surgery start and surgery stop is about 29 minutes. Does that look right?
Yes, that's exactly correct.
And I mentioned that in relation to my question about the MAR, whether, the fentanyl infusion, how that would be impacted by the surgery time.
Yeah, so looking at this, it does appear that during that period he was receiving the fentanyl infusion.
And you were shown an order and a MAR that was correlated to the surgical procedure, which had an order of fentanyl for 14,321.2494. Do you remember being shown that documentation? Correct. I just wanted to be clear about this is the anesthesia record and that number purports to be there. Do you see that?
Correct. Apparently the anesthesia team was reading that either off the infusion pump or somewhere else, because obviously one could not receive that much fentanyl in 30 or 40 minutes in the OR. So it looks like they were counting from what was on the pump.
Well, so I want to get to that. Do you agree with me that the next page on the anesthesia record indicates, and we know these medications were administered for the surgery, were they not? The midazolam, the fentanyl, and the propofol?
That's correct.
And those amounts, if you recall, the 3, the 30, and the 550 are all accurate?
Yes.
And then we've got that 14,000 microgram number of fentanyl repeats itself there on this anesthesia record as well.
Correct. And then embedded in that black line is a number which I could not read. Again, it's easier when you're actually looking at the electronic record, but you can see there's a number that was embedded in there.
And I just want to say here, the surgery time appears 12:05.
Correct.
And then here, we've got on this record, the fentanyl is 11:44.
True.
And then I want to just go back here to correlate it, that 11:44 is when it appears Mr. Simmons was taken in transport to have that surgery.
Yes, that's accurate.
So these, and that fentanyl, those orders, those administration of that fentanyl was not related to Dr. Husel. You would agree with me on that?
Yes, I would agree. Dr. Husel was not involved in delivering anesthesia to Mr. Simmons.
Let's go to Ms. Hodge. Ms. Hodge was a patient that actually, as she wheeled into the ER, she was having a code, was she not?
Yes, that's correct.
And I just want to go through something that you said on your direct examination with respect to the survival rate of individuals that are given CPR before they arrive at hospitals. Do you remember that testimony?
Correct.
And then you gave a different number to the jurors about the likelihood of survival when someone gets CPR within a hospital.
True.
Are you familiar with the National Academies of Sciences, Engineering, and Medicine?
I'm not a member. I've heard it referenced.
Showing you what's been marked as Defendant's Exhibit Hans 23. This article that I'm showing you appears to just be titled Cardiac Survival Rates, around 6% for those occurring outside of a hospital. Do you see that?
I see that listed in this paper. I've never seen this document before in my life.
You haven't?
No.
I have provided it to the state, Your Honor. So my question about this is, would it surprise you to know that there was a study done by the National Academy of Science, Engineering, and Medicine that indicated that every year 395 cases of cardiac arrest occur outside of the hospital, so about 400,000.
That number doesn't surprise me. That's consistent with what the American College of Cardiology reports.
And then they further find in their study that less than 6% of that 395,000 survive.
You'd have to figure out what their marker was for survival. Was it leaving the hospital? Was it surviving 30 days? I don't know that specific study.
And that's certainly lower than the number that you gave, though, when you testified.
Correct. It's not consistent with other data offered by the American Heart Association and the American College of Cardiology.
So let's go to Ms. Hodge. Paragraph 29, you, again, kind of a repeating statement, but you've included with Ms. Hodge as well. It appears he, Dr. Husel, did not delineate Ms. Hodge's status. It was not yet terminal, and further medical surgical interventions had not been exhausted. So with respect to that finding, I just want to show you Joint Exhibit 7, page 19 to 21. We know that she arrived on April 1st.
True.
And physician note right here indicates which doctor?
That's Dr. Glucker, who is the emergency room physician that first took care of him.
Dr. Glucker seems to do the physical exam that you talked about on your direct. Does that sound right?
Yes, that is correct. That's documented on this page that you're showing.
And with respect to the cardiovascular findings that he makes, he writes that there are no heart sounds, right?
That's correct. When he listened, he did not appreciate heart sounds in the absence of CPR.
Then he further notes that femoral pulses are present with CPR. However, there are no palpable pulses when CPR is not performed. Would you agree that that's his finding?
Yes, I would agree that that's what he found.
Then immediately, treatment and medical decision-making. Patient is intubated by myself. See procedure note.
True.
And then he goes on to say what's done there, and then he indicates that the EKG seems to have been done.
That's correct, and had a significant abnormal finding.
I was going to ask you about that. There's a significant abnormal finding on the EKG.
Correct.
BP's blood pressure
Yes, blood pressure.
remained low, and patient was placed on vasopressor.
Correct. Levophed is a vasopressor.
Then, after all that, she has another episode. She codes again.
True.
Another round of CPR was started, but this round is in the hospital.
That's correct.
And what's CXR?
That's chest X-ray.
Confirmed tube placement, but show pulmonary edema versus ARDS.
Correct.
And then this is continuing to be the ER physician note. Patient remained in very critical condition with poor prognosis.
Yes, that was Dr. Gluckert's assessment.
And right above it, severe acidosis, right?
True.
She's getting the bicarb.
She is.
That doctor's name.
Sure, it is GLUE, G-L-U-E-C-K-E-R-T. And then just going to Ms. Hodge, that history and physical, this appears to, it says up here, dictated by Genevieve Deichel. Do you see that?
That's correct. D-E-K-I-E-L.
And talks about how the Ms. Hodge had a code while she was at home.
Correct. A witness cardiopulmonary arrest.
And why I asked you about the stats for someone that has CPR outside the hospital is because from the medical note, we know that bystanders that were with her when she had the code, they gave her CPR before she was at Mount Carmel.
Yes, they did.
And then she achieved a pulse, and then pressure started. This is at the hospital, and then again she lost the pulse.
True.
Underwent one round of epinephrine with regain of pulse,
Yes, that's accurate.
right? And then she lost the pulse again.
Correct. She had developed atrial fibrillation and low blood pressure, the hypotension, and then lost a pulse again.
And every time she loses a pulse, you would agree with me that in medical terminology, that's considered a code.
Correct. The loss of a pulse is called the code blue situation.
I'm going to go to page 227 of your deposition. Where you are asked questions about how every time someone has a code, you essentially reanimate them to life. Do you remember testifying as to that?
Yes, that's correct. Every time you initiate basic and advanced life support, you are reanimating their perfusion and thus restoring their life capability.
And then it's page 219 of his deposition. One moment, Your Honor. I will find that quote. Thank you. Which page? Two what? 227, sorry. Just one moment, Your Honor. I will find that in just a second. 1 second. Okay. There was a question you were asked, and maybe it's just easiest to ask you this, in your deposition about every time someone codes, isn't it true that their life expectancy decreases?
That's correct. With each subsequent code, I would counsel the family that it becomes less likely that they will have a good long-term prognosis.
So with respect to Ms. Hodge, multiple codes.
Yes, definitely. She had documented multiple code blue events.
And you would agree with me, multiple codes in a short period of time. This is all one day.
Correct. It was all on one day.
I want to talk a little bit about acidosis. I know it's been something that's talked about, showing you Joint Exhibit 7, page 90. With respect to Mrs. Hodge acidosis level, it's indicated, is it not, as a 6.73?
That is correct. That's what's documented.
And when in the medical field or healthcare profession, with respect to pH levels, there's a high range and a low range, is there not?
That's correct.
And on direct, you were asked questions about this, but fair to say that anything under a 6.8, is considered not sustainable with life.
That's correct. Unless there is a rapidly reversible cause, such as diabetic ketoacidosis, I would agree that it bodes for a very poor prognosis and reflects severe metabolic acidosis.
And we have this measurement on her at 4.1.
Yes, we do.
At 2003.
Correct.
And just as a follow-up, I know you indicated in your report, doctor, that when you talked about my client's notes with respect to Ms. Hodges' extubation, you called it a death note. Do you remember that?
That's correct.
I'm just showing you progress notes with respect to Ms. Hodge. I know that's your characterization of it, doctor, but I want to be clear that death note as a either medical record terminology or as any notation entered by Dr. Husel never appears. The death and note.
In this specific note, no. There were other examples in other patients in which the term death note was included.
And I wrote down that you mentioned it with respect to Ms. Hodge. So while we're here, patient arrived in code, right?
Correct.
Family updated regarding grim prognosis.
True.
And then the note indicates all family members in agreement with DNRCC.
That is what's stated in this note.
And do you see how members is plural?
Yes, the members would imply more than one.
And if you recall from your review of the medical records, Ms. Hodge was fortunate to have quite a large family there with her at bedside, was she not?
Yes, she was.
Moving now to Ms. McDonald. Cancer survivor?
Yes, ma'am. She was a ovarian cancer survivor and had been in remission for 3 years before her return of the cancer.
But then we've subsequently learned from the medical records that the cancer returned, did it not?
That's true. She had come out of her remission and now is battling cancer once again.
And then on top of the ovarian cancer, it had metastasized, it had spread.
Yes, her oncology notes infer that she was receiving this aggressive treatment because of the spread of the cancer.
I want to go with respect to Brandy McDonald is to your note on 31. Again, same note where it appears that Dr. Husel, failed to clearly delineate Ms. McDonald's status was not yet terminal. So just showing you Joint Exhibit, page 18. This is a consult by Dr. Stoycheff.
Correct. Stoycheff.
And if you recall from your review of the records, which type of doctor is he?
He was a kidney doctor brought in to consult about her renal failure.
Because her kidneys were failing.
Correct.
And this is his consultation note, Joint 5, page 2021. It says, does it not, that the patient is critically ill with severe lactate acidosis?
Yes, that was his opinion.
And we just talked about acidosis and what are severe numbers, right?
True.
The possibilities for this include her liver failure versus metformin toxicity.
Correct.
Right now, she is rapidly getting worse, and I am concerned given her pH is now 6.9.
That's true.
And we had just talked about, with respect to the scale that is used by healthcare providers, 6.8 is not sustainable with life.
Correct.
And then he talks about other measures that he would like to do. And further consultation note says, does it not, severe pH, and now she is in danger of cardiac arrest. Lactic acid rapidly increasing.
Yes, he does indicate that sentence.
Then further on, now we have Dr. Klosser. So a second doctor indicates on 115, the patient is critically ill with impairment of one or more vital organ system, such that there is a high probability of imminent or life-threatening deterioration in the patient's condition.
That's correct. That was his notation.
And Dr. Klosser spends, as he notes, 83 minutes with that patient.
True.
And her cancer was such that she was part of this aggressive experimental treatment, was she not?
Yes, she had enrolled voluntarily in an experimental protocol to try to once again bring her ovarian cancer into remission.
And then I want to show you a note, Joint Exhibit 5, page 46 to 47, with respect to Ms. McDonald. Third doctor, would you agree?
That's correct.
And the notes here, patient is critically ill, poor prognosis.
True.
And this is the doctor, Dr. Chand, on 114, that says they began the discussions with the husband, mother, and father. Do you see that note?
I do see that.
They do not want heroic measures should this patient have a cardiac arrest. Do you see that?
Correct, that's true.
But want us to try all other means, including dialysis, if needed.
Yes, that's accurate.
Okay, and then of course the code status was changed to DNR-CCA.
True.
And that note says, but they're willing to try dialysis if it could work.
That's correct.
And dialysis was tried.
Exactly.
Joint Exhibit 5, page 283. Doctor, you would agree with me that because the family said she doesn't want any more, but maybe we just try dialysis, they did.
That's correct. They gave her a trial of CRRT, but it appeared that she clotted off the filter of the machine, so they had to terminate it. They tried to resume it. They stopped it at where she clotted at 2 p.m. They tried to resume it at 2:40, and then by 2:59, her blood pressure went down, so they stopped because with dialysis, you have to pull the blood out of the patient, so her blood pressure down, and they then stopped the attempt.
So they tried twice with dialysis.
Correct.
But her body just couldn't do it.
It did not appear that she could tolerate it at this time.
Your Honor, I can finish up this patient and take a break if you'd like. I only have maybe 1 or 2 more minutes. It's up to you.
Okay.
Just showing the witness.
We're a little ahead of time, but it's probably a good time.
Oh,
to
I'm
break.
not finished with it, but I'll.
Yeah, go ahead and finish up this particular patient. And
Thank you. And then just want to take this off. Just want to show that this is the discharge summary, and this appears to be Dr. Shand, right?
Correct. He was the hospitalist.
And he was the one that we saw that had previously seen her when she first arrived.
Correct.
And just want to go to his note down here that the patient continued to decline, requiring high pressors. So that's vasopressors, right?
That's true.
And was in fulminant hepatic failure.
Correct.
Tell the jurors what that means.
So hepatic failure means that her liver was failing, and fulminant means that it appeared that it was trending towards end stage.
And that's why they tried that dialysis twice.
Yes, that, and because she appeared to have metformin toxicity, which was a medicine she was taking for diabetes, but that can cause acidosis.
And one last thing with respect to Ms. McDonald. She was on 2 different vasopressors, was she not?
That's correct.
And I'm showing you Joint Exhibit 5, 296 to 297. This is her systolic blood pressure.
Correct. That's the upper number, the systolic blood pressure.
And do you see, as of 1/14/2151, do you see what number it is there?
Yes, at 9:51 in the evening, her upper number was 42.
And this was before she was extubated, is that correct?
Correct.
And if you could just generally see the trend, doctor?
She had a downward trend.
And it starts, does it not, at 14:06? It's 116.
Correct, at 2:06 in the afternoon, and then it trended downwards.
And then it's so low that it gets to a 42, and then do you see how it gets to a 40?
That's correct.
Tell the jurors, if you could, what is not sustainable with life with respect to systolic blood pressure?
Usually a sustained systolic blood pressure below 65 would not be consistent with a patient being able to sustain life.
And I just want to show you the back page that on this side, so we have 42, so she's got 42 over 28. Does that look right, doctor?
Correct. The diastolic blood pressure, the lower number, was at 951, was 28.
And what's a normal person's?
A normal person's is between 70 and 85, so this is quite low.
We're at the not sustainable with life phase here, aren't we, doctor?
Correct. If this were to continue, it would certainly pose a threat to her life imminently.
Your Honor, we can break if you would like.
Okay, sounds like a good idea. Ladies and gentlemen, 15 minutes. I don't know about you, but I'm warm, so. All right. It's getting a little toasty in this wool. Okay, have a great break, 15 minutes. Doctor, remember the admonition, go have your break, get out of this hot room. Okay. First things first, Ms. Brebb, anything for the record?
Not at this time, Your Honor. Thank you.
Ms. Menashe.
No, Your Honor. Thank you.
Okay, when we were in conference earlier, we talked